So to understand why we do what we do in knee replacements, we need to work backwards from the conclusion. The conclusion, of course, is that we want the patient to have a pain-free knee replacement that has a functional range of motion and it's stable through that full range of motion. But to achieve that, we have to have the collaterals be happy and the patella tracking should be appropriate. This in turn depends on the gaps between the femur and the tibia. And this in turn depends on the implant position. The implant positions, of course, depend on the bone cuts. And the whole idea of where you make the bone cuts will depend on your understanding of the definitions and principles related to total knee replacements. In order to describe the position of a total knee replacement, it is important to define a reference frame. And to that end, a few axes have been described of the lower extremity. One such axis is the weight-bearing axis of the body that is a plumb line from the front of S2, which is the center of gravity of the body. The other is the weight-bearing axis of the lower extremity, which is a plumb line from the hip center. However, these axes are not very well reliable because they can move when the body's weight shifts from one leg to the other. So these are not conventionally used in total knee replacement. The mechanical axis of the lower extremity is defined as the line that is drawn from the hip center to the center of the tibial plafond. The mechanical axis of the femur is defined as a line from the hip center to the notch of the distal femur. The mechanical axis of the tibia is a line drawn from between the spinous processes to the center of the tibial plafond. The anatomical axis of the femur is a line that bisects the canal of the femur. Note that it exits into the medial femoral condyle and not into the center of the notch. The anatomical axis of the tibia happily coincides with the mechanical axis of the tibia. The mechanical axis of the lower extremity can sometimes give us an idea of the varus or valgus deformity of the knee, such as in this case, this knee on the left is ever so slightly valgus. On the other hand, this knee on the right side is invarus. It is very important to understand varus and valgus in relation to the knee, not only the relationship between the two bones, but also in terms of description of the joint line and the description of the position of the implants. I want to explain how angles in orthopedics are defined. There are two caveats. The first is that the angles describe the distal segment in relation to the proximal segment. And the second is that the proximal segment should be in the quote-unquote normal conventional anatomical position. So if this is the lower extremity, this position of the knee we all know is varus. And one way of defining this is if the angle or the apex of the angle is pointing laterally, this would be a varus deformity. However, using my above definitions, the varus deformity of the knee is really defining the tibia, which is the distal segment, in relation to the femur, which is the proximal segment. And the femur, being the proximal segment, has to be in its normal conventional position. And when the distal segment moves medially, we call it a varus deformity. On the other hand, this is obviously a valgus deformity or knock-knee position, and the apex of the angle between the femur and the tibia is pointing medially, and therefore this becomes a valgus deformity. But another way of describing this is that the tibia, which is the distal segment, is moving away from the midline in relation to the proximal segment, which is the femur, which is in its conventional anatomical position. I know this seems pretty obvious, but it may also seem that I am confusing the definitions, but this will become more evident when we talk about the implant positions and the joint lines. Look at the x-rays of this patient that I operated on recently and draw some lines. This would be the mechanical axis of the femur, and this would be the mechanical axis of the tibia. As you can see, there's about a 7.5 degree varus deformity between the tibia and the femur. If this is 180 degrees, the tibia moves medially and the apex of the angle is lateral. So this is a varus deformity of the knee. In this x-ray, if we measure the angle between the mechanical axis of the femur and the tibia, you see that there is about an 80 degrees of valgus, and it's valgus because the tibia moves laterally and the apex of the angle is medial, and so there's about an 8 degrees of valgus on the femur. On this x-ray, if I draw the mechanical axis of the femur and then draw the distal femoral articular axis, we see that there is about a 5.5 degree valgus angle. So in this case, the distal femoral articular axis is about 5.5 degrees. And this is because a 90 degree angle would look like this, but the distal femoral articular axis is about 5.5 degrees in valgus. So if I draw the mechanical axis of the tibia and the proximal tibial articular axis, we see that there is about a 4 degree varus angle, and the reason being that 90 degrees would have been here and the tibial joint line is about there. Now it gets a little confusing, and therefore, according to what I explained about the definition of varus and valgus, this is the distal segment, this is the proximal segment. So if you bring the proximal segment back to where the conventional position would be, and that would be at horizontal to the floor, then the mechanical axis would travel towards the midline, and therefore this angle is conventionally known as a varus proximal tibial articular axis. So let's talk about the implant here. The femoral component here is at about 90 degrees to the mechanical axis of the femur, which puts this in a neutral position. And the tibial component is ever so slightly in varus of about 1.6 degrees. Example of a knee replacement that is causing a valgus deformity of the lower extremity by about 6 degrees. And if I measure the position of the femoral component, it is in about 4.5 degrees of valgus, and the tibial component is neutral at about 90 degrees. Example of a knee that is in about 20 degrees of varus And if you look at the femoral component, it is roughly at about 15 degrees of varus, because the joint line should have been about here, but it's in about 15 to 17 degrees of varus, whereas the tibial component is about 3 degrees of varus. So here is an example of a knee that is in about 6 degrees of varus, and when you look at the distal femoral component, or the femoral component and the distal femoral articular axis, it's in about 3 degrees, 2 to 3 degrees of valgus. But when we look at the tibial component, it's in about 7 degrees of varus. This would be a varus position of the femoral component, and this would be a valgus position of the femoral component. This would be a varus position of the tibial component, and this would be a valgus position of the tibial component. For the left knee, this would be considered internal rotation of the femoral component, and this would be external rotation. Internal rotation, external rotation. For the left knee, on the tibial side, this would be considered internal rotation, and this would be external rotation of the tibial component. Internal rotation, external rotation. The Q angle, also known as the quadriceps angle, is basically the angle between the quadriceps tendon and the patella tendon. In some textbooks, it may be described as an angle between a line drawn from the ASIs to the center of the patella and an extended line from the patella tendon. Basically, there is a vector pulling upwards towards the ASIs and another one pulling downwards towards the tibial tubercle. This causes a resultant vector to be directed laterally. When this angle is much larger, the resultant vector can be much larger, causing the patella to dislocate laterally, and also increases the joint reaction force between the lateral facet of the patella and the lateral femoral trochlea.